Hi, hopefully everybody can hear and see me. I just wanted to say a quick welcome to everyone and thank you for coming to this webinar tonight. This will be a chance for you guys to learn a little bit about some of the research that the Cerebra network and the team there have been conducting over the last sort of few years, but with a view as to what they're actually going to be doing going forward and how you guys might get involved with that and learn a little bit about SMS. There are 3 projects that they're currently running, and I'm going to hand over in a minute to Caroline and Stacey and Rory to talk about those. Before we do that, I just wanted to quickly mention that if anybody has any questions that they would like to ask, you should have a link at the top, an icon that says Q&A. We will do our best to answer what we can, and what I would say is to try and avoid any kind of personal questions or clinical questions that you might have around your own person with SMS, and actually just keep the questions that are sort of generic to with regards to the actual research projects. There is also, at the end of the webinar, there is a link to a sort of feedback survey, and we would really appreciate any feedback that we can get on this event. It helps us to plan future events and do similar things in the future. You can find the link to that if you click on the chat icon at the top. It's the first icon. You'll see there's a link to the survey, but there's also a little steer for the first 2 questions, because it will then steer you to the right questions for this particular webinar. I've also stuck in the chat box a little bit of further information about 2 of the projects that the Cerebra team are going to be talking about today. They also have links to surveys. So hopefully that is okay. And I'm going to apologise firstly, and this is the first time I've ever done a webinar, so I'm learning the technology, so please bear with me and I will do my best to make Caroline the presenter. So there we go.
Thanks, Leanne. So I'm just going to pull up some slides which hopefully you'll be able to see. Can you see those okay? Yeah, brilliant. Well, thank you so much for taking time out of, I'm sure, your busy, slightly hectic evenings to come and hear a little bit about what we've been doing at the Cerebra Network and what we're hoping to partner with you on. For those of you who don't know me, I'm Caroline Richards. I work at the University of Birmingham as a researcher, and I'm also a clinical psychologist. And with another hat on, I am also chair of the Professional and Scientific Committee for the SMS Foundation. So it's always just a massive privilege for me to come and speak with you guys about some of the work we've been able to do so far with you. So the plan for today is myself and then Stacey and then Rory are just going to share a little bit about some possible opportunities really to partner with you in research. But I wanted to give you a little bit of background beforehand about who we are and what we're doing, really, for those, especially for those of you who are new to Cerebra. So we are a collective of researchers spanning 4 institutions. And the research that we're doing is really motivated by the fact that when children have neurodevelopmental conditions, they tend to experience poorer developmental, poorer health and poorer well-being outcomes compared to their typically developing peers. And that is something that we think is fundamentally sort of unjust, but also something that fundamentally research can help to change. And so we've kind of put together this network of researchers who at the heart of it really believe in collaboration, both collaboration between academics and clinicians, but particularly collaboration with you as the experts, as parents and carers for people with Smith-Magenis syndrome. And our aim is really to underpin the research evidence so that there will be better assessments, better interventions, and most importantly, better outcomes for children with rare and complex needs and their families. And apologies in some ways for that slightly unusual term, children with rare and complex needs, but we work with children and adults with lots of different neurogenetic conditions. And we're aware that for lots of those children and adults, there are a complexity of services that are needed around them in order for them to have the best possible outcome. So that's sort of what that term means. And for those of you who've worked with us for a while, you will know that in 2020, we established the Cerebra network. But prior to that, we'd always worked in this area, but worked with one of our colleagues, Professor Chris Oliver, who was my PhD supervisor, but also supervised my colleagues Jane Waite, Hayley Crawford and Joe Moss. And after being trained by Chris, we kind of carried the vision for doing research that makes a real difference to children with neurogenetic conditions, and split out into 4 different institutions where we run this programme of work. And our real kind of goal is to, as well as doing the research, to train up a whole new generation of researchers who are going to be passionate about championing research for children with complex needs of rare neurogenetic conditions and get really high quality research training. And so at the moment, we have a pretty large team spread across those 4 sites. And so we're beginning to realise some of that potential impact through training. What we're hoping to do over the course of our research is focus on the areas of need that families have told us are most important. And for children with rare conditions, there have been 4 areas that families have highlighted as really important. The first of which is co-occurring diagnoses, in particular autism. The second of which is sleep, which might be particularly pertinent to many of you here today. The third of which is mental health. And the final area is behaviour. And what we try and do is, across all 4 sites, take a really holistic view at all of these different areas, understanding that impacts in one might impact another. And when we're looking at these areas, we're kind of asking 4 questions. So our first question is, can we improve the identification of strengths and problems in these areas? So, for example, many families who have a child with a genetic syndrome have told us that it can be really difficult having their child assessed for any co-occurring conditions like autism. And often professionals might say, well, actually, that's just their Smith-Magenis syndrome, or that's just their Down syndrome. And so we are working really hard to improve good access to clinical tools that can help to screen and support diagnosis of autism in the context of a rare neurogenetic condition. Secondly, we want to use that improved identification to build better causal models. So another example would be that for children and adults who speak few or no words, who might struggle to put a label on their internal states, identifying anxiety is really difficult, because quite often if somebody is anxious, the ways that professionals will identify that is through asking them how they feel, asking them to tell them about situations where they feel that more or less. And that can be really difficult if you don't have expressive language. So my colleague Jane Waite has been leading work improving identification of anxiety in rare syndromes, so that we can then understand how anxiety might interact with children's daytime behaviours. Do we see perhaps more difficult behaviours or more withdrawal when children are more anxious? And therefore, can we improve our interventions for behaviours because we now know something better about one potential cause? So the next step we always take is around developing and piloting interventions. And where we've made great grounds in that, in particular in Smith-Magenis syndrome, has been around sleep. And a couple of the projects we're going to talk to you about later are going to particularly focus on that. And then finally, we are really passionate about taking our high quality, high rigour research back into the real world so that we can improve outcomes. So translating this into resources for clinicians, translating this into changes for policy, so that changes actually affect everyday families on the ground, regardless of where they live in the UK. So one of the ways we do a lot of that translation is through guides. And some of you might have heard of us because of guides you've accessed through Cerebra, the charity that fund us, through their website. So we've written guides on sleep, on anxiety, on pain, on autism in syndromes, and all of those are freely available and downloadable from the Cerebra website. We also help to co-produce a variety of infographics. This is one of our favourite ones. It's a really simple and so important scale to identify pain in children and adults who may, again, have few or no words, so may not have the ability to verbally express that they're in pain. We've also produced a series of training videos, which we use with when we're training clinicians. One of the things we really love to do, and actually this is more of a privilege for us than perhaps even for you guys, but we love to come out and spend time with you at support group days. I'm really excited for the upcoming SMS Foundation days and the kind of change in those. I think those are going to be really exciting for you as families and a great source of support. And actually it's those conversations we have with you on family days that end up showing us the right direction to take in the research that we're doing. We've produced, as I said, a series of assessments, so that improved identification. What we do when we've kind of got to a point where we're confident that our new assessments work is that we make them freely available online, not behind a paywall, so that any clinicians or families can use those. And we do that through a website called Further Informed Neurogenetic Disorders, or the FIND website. And really that's one of our main ways of sharing with you research, but also resources that might be useful for your family GP or for your paediatrician. Okay, so that's a little bit about who we are. And then I'm just going to finish by telling you about one of the studies we wanted to tell you about tonight that you could choose to take part in. And we're going to present 3 studies, but what I want you to take away in particular from tonight is that our goal is to partner with you. And so across these 3 studies, we're really hoping that given the age of your child or adult, the things that are important to you, that you will find at least one study where you think, yes, it would be helpful for me to be involved in that. I can see how it would improve the research evidence, but I can also see some personal benefits to maybe taking part. So the first study is called the BEOND study. And this really taps into those first 2 kind of aims we have around improved identification and building good causal models. I just want to show a quick video about BEOND, and hopefully this gives you a sense of why this might be important.
One of the biggest questions that we still don't fully know the answer to is how and why we change in the way that we think, feel and behave over our lifetimes. We've been partnering with charities and families of children and adults with rare genetic syndromes over the last 20 years to work towards answering these questions.
We know from our previous work that there are a number of key areas that we need to understand better to give every child and adult the best chance of a happy and healthy life. We know these factors are particularly important for children and adults with rare genetic syndromes.
BEOND is a pioneering international multi-site online survey that will follow children and adults over their lifetimes, focusing on those key areas. Through this, we will raise awareness and understanding of rare genetic syndromes, which is at the heart of what we do at the Cerebra Network. Beyond stereotypes, beyond stigma,
Beyond labels.
To take part in BEOND, please follow the link in the video caption.
So over our research careers, one of the things we've done is try to describe the strengths and difficulties that children might experience. And we've done that in a variety of syndromes, which has led to a series of publications that have helped to describe some of those things. But the last time that we did that was back in 2012 and was working with Chris Oliver. And since then, there's been huge improvements in genetics and the breadth of phenotypes that have been identified in lots of syndromes, including Smith-Magenis syndrome. But also, as we've spent more time with families, one of the questions we always get asked is, what will my child be like when they're an adult? What will my adult be like as they get older? And the data we'd collected so far had mainly focused on the here and now or a couple of years. And so we had this kind of real goal with BEOND to be able to track individuals over their lifespans so that we could provide you with more concrete and more helpful answers around what might happen over the course of your child or adult's lifetime. And this is one of our kind of flagship projects that we're running across all of our sites in the Cerebra network. I just want to show you why it's important, why we think BEOND is important. So this is taken from some of that very early data, the data we collected before 2012. It's a really complicated table, but it shows a variety of different genetic conditions. And then it shows a variety of different psychological characteristics. So we've got data on autism, data on affect or mood, data on hyperactivity, and data on difficult behaviours. And I just want to draw your attention to the very bottom box. So where you see a 0 or a circle, that means that this is similar to other syndromes. Every cross you see means that this is more likely in this syndrome, in this case Smith-Magenis, compared to at least one other syndrome. And where the more crosses there are, the more syndromes it is more common in than, if that makes sense. So one of the things to note is that we have found cross-sectionally, so at one time point, children and adults with Smith-Magenis syndrome show really high levels of impulsivity and really high levels of self-injury compared to other children and adults with different syndromes. So what this begins to show to us is that there are areas of specific need that if I was a clinician meeting a person with Smith-Magenis syndrome for the first time, I should be aware of, and I might want to assess that more than I would say for a child with Cri-du-Chat syndrome or Cornelia de Lange syndrome. And we find similar things, so this is the same sort of idea comparing across syndromes when we look at things like difficult behaviours. And so we see here, as I'm sure many of you are aware, self-injurious behaviours can be really common in Smith-Magenis syndrome, but actually physical aggression is maybe as common in SMS as it is in a variety of other syndromes. And so again, this helps me as a clinician to think about what should be the priorities, but hopefully also arms you as families to say, this is something I need you as a teacher or as a clinician who's working with my adult or my child to be able to help support. Critically, what I would say is all of the things we've done so far have involved these kind of comparisons across groups, and we want to keep doing that because it enables us to say what is shared, but also what is unique in particular syndromes. But really importantly, we want to push forward with the idea now of looking over time. So in BEOND, what we plan to do is to send out a survey where you will answer questions on behalf of your child or adult across a domain of psychological characteristics, but that we will repeat that every couple of years. So we'll come back to you and ask you the same questions again. What we will do is provide you with an individualised, personalised feedback report at every single time that you take part. And if you take part at one time, that doesn't commit you to take part at a later time. And what these feedback reports can be really helpful with is describing your child at a given time, but also as you take part over time, we'll be able to make comparisons in terms of change over time. And we try and write these in a really accessible way so that you can use them maybe in your child's local context or your young adult's local context. Those feedback reports in particular, we've co-designed with parents so that we can make sure they're as useful as possible for you. So just to finish very briefly from me, what would it look like for you to take part in BEOND? Well, firstly, you would need to go to this website or use this QR code to take part, and these will all come back up again at the very end of the set of talks, so don't worry about getting them down now. Or you could go to our website, the Cerebra Network website, to find out about how to take part. Or you could go to the website and then request that we send you a paper and pen pack. So most of this is digital, but we fully understand that you might want to take part on paper instead, so we can post it out to you if that's easier. And then you just follow the link, you provide us with some very initial answers, and then we make sure that you get the right set of surveys. Now, this study is open to anyone anyone who's a parent or carer of a child who is 1 through to 99. There'll be different questionnaires that you might see depending on the age of your child, and you'll see different consent forms, but anyone can take part. The questionnaires are designed for you as the parent carer to complete, and they're all in English. At the minute, it takes about 60 minutes to complete, which we appreciate is a long time, but we've set up the survey so that you can stop and start it and come back to it when you've got time. So if you've got 5 minutes sat in front of the telly or waiting for the washing to go out, or I don't know, maybe even drinking a hot cup of tea, well, perhaps less likely when you're more likely when you're doing 1,000,001 other things, you can do a little bit of it and then put it down and come back to it. So what you'd need to do is complete the information sheet and the consent form. we'd ask you to talk to the child or adult that you care for at a level that they will understand, and to give us some information about whether or not they were also happy to take part, if that's appropriate. You'll see some additional consent forms and information sheets about longer term staying in contact with us. So that might involve taking part in future stages of BEOND or hearing about other research that we're doing. And then you'll get to the survey items themselves. And then as I said at the beginning, crucially, once the data are all collected, we'll then send you out an individualised feedback report at the close of the study. So that's BEOND. I'm going to hand over now to Stacey, who's going to tell you about another project that we have available.
Thank you very much. I'm just going to share my slides. Okay, can everyone see my slides? Yeah, great, thank you very much. Hi, so for those who I've never met in person before or via online calls, my name's Stacey Bissell. I'm based at the University of Birmingham. I've been working on some of the research that Caroline's presented, and I work with Rory on some of the research that we're currently conducting. I recognise some familiar names of the people who have attended today, so it's really nice to be able to present some of our work to you, and some information about a very, very new study that we're conducting. So Leanne's added into the chat some information about two of the studies, so BEOND and what Rory will be presenting on. But this study about napping in SMS is new, and we're going to be data collecting from January. So don't worry, you haven't missed any of the information or recruitment information. We've not actually launched this. We'll be launching in January. So I just wanted to set a little bit of a context as to why we're interested in investigating the provision of a daytime nap on sleep quality in Smith-Magenis syndrome. So similar to what Caroline presented in the table with the crosses and the noughts, we've been able to compare across syndrome groups, looking at sleep parameters in particular. So on this table, you can see information relating to sleep parameters across 3 genetic conditions and autism. And I just wanted to highlight daytime sleepiness. This is one of the sleep parameters that we can use when we're thinking about the provision of a daytime nap and how that might affect overnight sleeping, especially in Smith-Magenis syndrome. So as you can see, there are 2 pluses for Smith-Magenis syndrome in relation to daytime sleepiness. This won't be a surprise, I don't think, to anyone who is attending today, that when we investigate sleep in Smith-Magenis syndrome, we see reduced overall sleep time, we see early morning waking, and as a consequence, we would expect to see daytime sleepiness. What was also came out of this study conducted by Jane Trickett, who some of you may have actually taken part in this questionnaire study, was that higher impulsivity was positively correlated with increased daytime sleepiness. So we're particularly interested in daytime sleepiness as one of our parameters of poor sleep in Smith-Magenis syndrome and its association with daytime behaviour. And this is taken from the broader literature just around sleep hygiene. But there's something called a sleep debt, which is when the amount of sleep we would biologically need doesn't align with the amount of sleep that we actually get. And there may be different contexts and different times within any of our lives where we're in a sleep debt, which means we would experience daytime sleepiness and irritability because we're not getting the amount of sleep that our body's telling us we need. And this is just taken from the broader sleep literature, that people compensate for a sleep debt if they haven't got enough sleep that they would need overnight. Adults would compensate for this with catching up at sleep on the weekend or taking naps. However, someone who's in a sleep debt of more than an hour, so if, for example, they need 7 hours of sleep, but for a night they've had a sleep debt, people get locked in this vicious cycle and don't necessarily compensate, or they're unable to catch up, and so they're in a constant sleep debt. And if it's longer than an hour, that does have biological effects in terms of tiredness and cognition and attention. A severe sleep debt would be for longer than an hour and a half, where for one night, if you are in a severe sleep debt of more than an hour and a half, that has significant consequences in terms of cognition, attention, behaviour, feeling irritable. I would argue, and some of you would attest to this, that children and adults with SMS are in a sleep debt because how much sleep they need biologically, they are not sleeping in a overnight as we would expect for their chronological age. So they wake earlier, they wake frequently throughout the night, and we might see then that the children and adults that we work with Smith-Magenis syndrome would compensate for this sleep debt. So you may find that they're particularly tired in the early afternoon. They may sleep before their usual bedtime, so they may sleep at around 6 p.m. And this is to compensate for that poor sleep, their poor total sleep time that they're getting overnight, that condensed period of sleep that we would expect to see. And so again, Jane Trickett conducted some Cerebra funded work looking at the association between daytime sleepiness, napping, and behaviours, notably overactivity and impulsivity, by asking caregivers to complete behavioural questionnaires alongside sleep diaries whilst their children were wearing what we call ActiWatches. So some of you will have received actigraphy feedback reports from participating in our research. And this is a very complicated association, so I'm just going to walk you through it and pick out some key points that we're particularly interested in when we're thinking about the relationship between total sleep time at night, what having a nap in the day does to that total sleep time, and whether there's an association between napping and behaviour. So there was an association between a longer daytime nap predicted shorter total sleep time that night. So that's something really important to bear in mind. The actual duration of a nap in the day is important. And I'll go on when I'm presenting the rationale for why we're conducting this study into napping in SMS, as to why the duration and the timing of the nap is particularly important and aligns with the information that you have also presented on your website in terms of napping. Also, there was an association between shorter total sleep time would predict longer nap duration the next day. So that goes back to that idea of a sleep debt, not getting the required total sleep time overnight meant that children were compensating the next day with a daytime nap. Afternoon sleepiness did not predict total sleep time that night. So what that means is that the caregiver rating of whether the child was sleepy did not necessarily affect how much sleep the child was getting overnight. Equally, total sleep time did not predict the next day afternoon sleepiness rating. So the nap itself was predicted total sleep time, but the rating of sleepiness by the caregiver was still prevalent. A longer daily nap duration predicted higher same-day sleepiness. So actually, if children were having, say, a 2-hour nap, they would get a higher rating that evening of being sleepy by the caregiver. And then the last 2 points relate to behaviour, so caregiver ratings of behaviour. So higher afternoon sleepiness ratings predicted higher ratings for that day of overactivity and impulsivity. And afternoon sleepiness ratings by the caregiver predicted higher irritability ratings for the same day. So there's a complicated picture in relation to how the nap affects total sleep time, how caregivers attribute daytime sleepiness in relation to whether a nap was present, or how it affected behaviour in relation to being sleepy. And that sort of mixed picture does align with some of the information that we gathered when we were conducting our mixed methods study. So again, I recognise some of the names. Some of you took part very kindly in our interview study about sleep management, and napping was mentioned. And from our caregiver responses in this study that me and Georgie Agar conducted, there was talk around actually avoiding a daytime nap, because then you would maybe enter that difficult territory around bedtime, especially if the nap happened too late or for too long. Then that actually had a knock-on effect for sleep that night, and then the next day behaviour, and sort of the catch-up and the rolling over effect, I guess, of what having a prolonged nap would do for that bedtime routine, but also how that would impact the next morning and maybe the behaviour within the school setting the following afternoon. So there are lots of things to consider when we're thinking about the utility of a nap as a potential intervention, and whether or not that is something that's recommended. So there are different approaches in terms of whether caregivers try and delay a nap, or structure a nap, or try and avoid naps. And what further complicates the picture is that napping in the behavioural sleep hygiene literature is actually discouraged for children. Your parents and caregivers are actually taught to phase napping out. So, for example, at 4 years of age, children would still maybe be having a daytime nap. Whereas when you think about attending nursery and then entering the school system, there aren't opportunities for naps necessarily, and so the nap is phased out. So actually at the age of 6, only around 10% of children are having a regular daytime nap. And then I just had a little browse of the SMS Foundation website with the new logo, and it's really comprehensive about the things to consider around sleep, and the guidance actually supports what we would say as well, and what came out of our interview responses, that daytime naps shouldn't necessarily be discouraged the way they are in the sleep hygiene literature for children without Smith-Magenis syndrome. But that the timing and the duration of the nap are important. So on the SMS Foundation website, it says that naps may be able to improve daytime behaviour, and particularly the nap during the middle of the day, so around lunchtime, is better, as later naps reduce the ability to sleep during the evening and nighttime. And that's also what we found when we were conducting these interviews, that some parents actively avoided naps because of that danger zone in the late afternoon and early evening. So I'm now going to introduce, I hope I've set the context as to why we're particularly interested in the effects that naps may or may not have on improvements in behaviour, and may or may not have on the overnight sleep. And this study is called the Napping Actigraphy Pre and Post SMS Study, or NAPS. This is a very new logo, this is very new information. And I'll just quickly present who is involved in this study. So predominantly the first picture is of Vix Turner, so some of you may recognise her from the SMS conference in Solihull. She was in attendance. And what we're doing in this study is asking caregivers to take part in an actigraphy study again, so with the ActiWatches, but particularly caregivers of children with SMS aged 2 to 6 years. Because what we're going to be asking families to be providing us with over a 2-week period is for their child, for the first week, to wear the ActiWatch, and for caregivers to complete a sleep diary as is. So as is the current routine for your child. And then after 7 days, and we will talk you through this process and maybe coordinate this with the school support as well. But after the 7-day period of wearing the ActiWatch as is, we will talk you through the process of introducing a structured scheduled nap that lasts no longer than an hour around midday. And so we might need to liaise with schools with this and to talk to you about when would be best and the context for you and your family. But we would be asking you to schedule this nap and complete the diary, and for your child to continue wearing the ActiWatch after this nap is introduced. And then we're interested in that pre and post introduction of the nap. So actually, do we see any changes post-nap in terms of behaviour and sleep quality using the sleep parameters from the ActiWatches compared to the pre-information that we've gathered from the sleep diaries and the ActiWatch before the nap was introduced? So I will share the information. I'll share these slides and to circulate these slides. But the main contact would be to directly contact Vix using the email address here, and I'll also copy it into the chat. Yeah, so thank you very much for your time. I'll stop sharing and introduce Rory.
Hello, I'm just going to start sharing. Give me 1 second. Okay, is that all good? Can you see that?
Yeah,
Yep,
we can see it,
okay.
Rory.
Sorry, thank you. Hi, so my name's Rory O'Sullivan. Many of you might not know who I am. I feel like I'm relatively sort of new on the scene, so to speak. I'm a PhD student at the University of Birmingham. I'm supervised by Caroline and Stacey, and I'm here to talk to you today about one of my studies called the Cerebra Sleep Project, which is, well, looking at sleep, as you might imagine, in Smith-Magenis syndrome. So I'll give you a quick rundown of what the study involves, and we've asked of your attention for quite a long time now, so I'll try to make this as snappy as possible. So Caroline and Stacey have done a really helpful job, actually, of outlining how important, well, sleep is in Smith-Magenis syndrome, but also impulsivity in particular. So my study is looking at quite specifically how sleep difficulties and impulsive behaviors during the daytime may interact with each other in Smith-Magenis syndrome. And when we're thinking about impulsive behaviors, these might be described by things like a difficulty waiting for things, wanting things immediately, perhaps acting without thinking first necessarily. So previous work has shown us that impulsivity is related to sleep difficulties in Smith-Magenis syndrome and in numerous other genetic syndromes as well. But it's actually quite unclear how these things are associated. And that's what my study's working towards, is trying to sort of unpick whether impulsive behaviors might be, influencing sleep difficulties, or if sleep difficulties are influencing impulsive behaviors. And by identifying that, we're hoping to sort of build models of cause, like Caroline was speaking about earlier. And from there, we can start thinking about, targets for interventions and, trying to, more rigorously tackle these difficulties. So that's a bit of a background for what I'm doing and why I'm doing it. So I'm going to go to the specifics now about the study itself. So in terms of who can take part, we're looking at children with Smith-Magenis syndrome across quite a broad age range, so from 4 to 15.5 years. And we're trying not to apply really any other strict inclusion criteria. So it doesn't matter if, your child has, sleep difficulties right now or not, or whether they are taking any sleep medication or taking part in any clinical trials. We really kind of want to capture a representative subset of all children with Smith-Magenis syndrome for this particular study. And so taking part involves these sort of 3 main phases. There's an online survey, which is relatively quick, taking about 30 minutes. And then we'll call you for a telephone interview, which is about an hour and a half. And then we'll move on to the main 10-day sleep assessment. It's worth noting that all of this can be done from home. It's completely remote. So it doesn't matter whether you're close to University of Birmingham or not. Yeah, you should be able to take part. So I'm going to speak a little bit more about the 10-day sleep assessment and what that specifically involves, because when I've spoken to families, they have most questions about this aspect of the study. So during the 10-day assessment, we'll ask children to wear a Fitbit-like device. It's this watch on the right, and what this watch does is it measures sleep. And we'll ask children to wear that for about 10 days during the day and at night as well. If you think it might be sort of helpful, we can offer kind of a practice watch before the sleep assessment to hopefully get, children perhaps used to the feeling and idea of wearing a watch. And the watch itself can be worn on, the wrist or an ankle. It can be worn over or under clothing. It can be put on just before bed if children don't want to wear it during the day. And by doing all this, we're hoping to make the study kind of as accessible as possible. And during the 10-day sleep assessment, whilst children wearing the watch, we'll ask them to complete some games using toys and a tablet that we send out as well. I've got a few videos on the next few slides that sort of demonstrate these games, but the idea for these was we're trying to make them as accessible as possible so children of all kind of ability can take part. And these will be completed over Zoom with us as well. So again, completely remote. And I've just dropped in there as well, caregivers will complete sleep diaries, if you wouldn't mind. So I'm going to give you an idea of what the games with the toys look like. So it's this one particular game, and I'll just give you a commentary of what's going on here. So we'll give you a selection of toys, and what I'll ask you to do is to sort of take one out, show it to your child, and just try to get their attention in it. And you'll just keep it out of their reach for a bit and say, look, but don't touch, and place it down on a surface in front of them and see if they can stop themselves from touching it. And in this particular case, we can see the wand was just too irresistible. Child just had to grab it. It's worth mentioning this video is from another study conducted at the University of Birmingham, looking at autism and intellectual disability. So we've practiced the games with, kids of similar ability to Smith-Magenis syndrome. Okay, and then we've also got these tablet games. So there's 2 here to show you. So one of them is the bubble pop game. We'll just ask children to press bubbles as they appear on the screen as quickly as they can. This one's actually a favorite of many children that I've seen so far. And we also have this game called Find the Puppy. Essentially, the premise is to press on the dogs as they cross over the screen, but to not press the cats, as you'll see there. So, yeah, that one is also a favorite. It's worth mentioning that whether you think your child might be able to play maybe just 1 or 2 of the games, and maybe not all of them, that's perfectly fine. We're really kind of happy to welcome everyone who wants to take part to the study, because one of our alternate aims for this whole study is to see whether the measures we're using are doing what we intend for them to do, and we can work towards developing better measures in the future. So actually getting out there and just practice using these games is really helpful for us as well. Okay, skip over that. And like Caroline mentioned with BEOND, there is a feedback report at the end, which we'll be very happy to sort of provide for you. And this will summarize quite a lot of information. So firstly, we'll have a sort of a summary of your child's sleep over the 10 days. So that's what you see on the right here with the blue bars. There'll be something like that which you'll get, which will show when your child may have fallen asleep and woken up and any sort of activity during the night. There'll be data from the telephone interview, which kind of summarizes child's sort of functioning on a day-to-day basis. And there'll be data from the games as well as the questionnaires. So it's a decent package of information, which will hopefully be really useful for you. Okay, and here's some information on how to take part. So I've got a QR code for my study here on the left, and that's my email down there at the bottom if you want to shoot me over an email if you're interested in the study or possibly taking part. And I'll keep these up here whilst we take some questions, I think, if that's all right. Is that okay?
Fab. Yeah, that's brilliant. Thank you, Rory.
Okay, no problem.
So we've had one question in the chat, which I think was about possibility of research abroad and in Germany. And I should have said, I didn't give a very good intro, but the BEOND study is international. So provided you are comfortable working in English is the only caveat. So we haven't been able to forward and backward translate all of the measures, which is what you have to do to be sure that they're still valid. So if you have sufficiently fluent English to be able to do the measures in English, we would love you to take part internationally.
I just can you hear me? Sorry, just checking.
Yeah.
I put a kind of comment stroke question in because it was just interesting for me with regards to the napping project, which is really hugely interesting because and the idea that I mean, I think we would all understand how the unpredictable and impulsive behaviours are connected to a sleep debt and to a disrupted sleep pattern. But I was just wondering whether you have any sort of recommendations for, like, when it comes to supporting a scheduled nap during the day for any children that are kind of more hyperactive and reluctant and resistant to having a sleep. Do you have anything or suggestions as to how we might make that happen?
I'm happy to answer this, if that's okay. Yeah.
Yes.
Hi. Yeah, I was hoping that you'd reserve this one for the discussion at the end, because I think it's a really important point, especially with the age group that we're working with. So this was based on some of the feedback that we had in the focus groups. I don't know whether Hazel remembers actually being at that school where we were talking about the provision of a nap within a school context. So the recommendation from the school for children with SMS that they work with who provide a nap, and this may not be possible in every single school setting, but it's really important to include it in the educational support plans, are around having a single occupancy room so that to minimise distractions. So some schools would maybe try and suggest having a quiet space within the busy classroom as the napping environment, and that's not going to work. But equally, for some children, it will be really difficult to be taken away from a really fun, captivating sensory environment and then be taken off to this quiet room where there's no iPads and no books and no social interaction, to then be told to take a nap. So the timing of the nap is really important. So what that school recommends was around having waking up for a lunch break part of the routine, and it might take a little bit of time to establish the exact timing, but the taking the child out of the maybe fun classroom environment to a quiet, minimal, dark, slightly cold room, it shouldn't be at a time where there's something really fun happening in the classroom. It should be at a time when it's sort of less fun, and maybe the one-on-one time with the TA away from the busy environment would be preferable. And then to schedule it just before lunchtime, so that the waking up out of the nap, the sort of consequence from waking from the nap is going straight into lunch. And that's sort of what's recommended. I don't know whether there's anything further to add.
No, it's just interesting. And some of the other feedback I had was from a teacher, was that the student never seemed to be tired because they were, you know, very hyperactive in nature. So I was interested because I thought, well, just because they're hyperactive doesn't necessarily mean to say that they're not tired. And sometimes I wonder again whether, you know, the tiredness and the sleep debt is actually making their behavior more hyperactive, because that's the way the child is coping with that? Is that also, it's trying to explain to, you know, educators that, you know, this is a problem for many of our children, and because they're a whirlwind in the classroom doesn't, you know, they're like, oh, they're not going to go to sleep because they're very hyperactive. And
it sounds a bit counterintuitive, doesn't it? That
yeah,
my child's really tired, so they're more grisly and irritable and more likely to maybe have an outburst. It seems counterintuitive, but I think the thing to say is that this is also a little bit of a feasibility study of like how feasible is it to introduce a structured nap and maybe develop some sort of protocol or guidelines that would be useful to feed back as well. If we find that caregivers in their interactions with schools or in the home setting are actually saying all of these things, that we had this scheduled time, but the nap didn't happen then, it happened 2 hours later, and then it significantly affected sleep. This is all really important information for us to work with as well.
Yeah.
Yeah.
Great, thank you. Caroline, do you want to read out the next one?
Yes, we've got a couple of, I think, complementary questions. So in the Q&A, Hazel has asked a question about whether there are plans to eventually extend all of our research into adulthood. And we've also had a comment. I don't know whether you can see the meeting chat as well as the Q&A. There's a comment from a parent or carer who said that they tried to take part in BEOND, but too many of the questions referred to young children. So working across the whole lifespan in SMS is something that we really, really want to do. We're really passionate about making sure that our research doesn't bias towards children, doesn't overly focus on children. And so BEOND is one of the first studies where we've tried to cover the whole of the lifespan. And in doing that, we've run into lots of challenges. And so I'm really sorry that you felt that the questions weren't all appropriate. And I completely understand that. And thank you for trying to take part. One of the challenges we face is if you want to measure something and measure how it changes over time, the only way you can do that is to ask similar questions over time. Otherwise, you're kind of switching to measuring something different. And so we have to pitch the questions in such a way that we can measure the same thing across time. And then we have to think about the fact that there's a huge amount of variability in just Smith-Magenis syndrome, but actually we're working with over 20 rare syndromes. And so what we don't want to do is have questions where a family might start trying to answer them, and on every single measure, the abilities and the skills we're asking about their child has not yet reached. And so all of the questions show skills that are just too difficult or not yet sort of developed in their child. And so we have to make sure that that the kinds of questions we ask span all the way down to the very youngest child, to children with the most severe disability. And then equally, we're trying to think about making sure that the questions go all the way up to the upper edge as well. So they ask about things that are important to adults, and they ask about things that change over time, things like mood, and they ask about things that might be higher level skills that develop as people get older. Now, the result of that is that the set of questions becomes quite long, and B, you are going to get asked some questions that might be at the wrong end for your child or adult. So they might be things that are not yet skills your child or adult has developed, or they might be things that actually they've developed and surpassed many, many years ago. And we appreciate that is less than ideal for families. We are looking for better ways to think about doing this, and would really welcome feedback from you if you can think of ways to do that don't then leave us unable to track change over time. But so far, doing BEOND as we are doing is the best solution we've found to a really tricky problem. Within BEOND, there's a load of streamlining which you don't really see, that based on some of the answers you give, certain bits of the survey get opened up or shut down, so that we're trying to do more of that streamlining. But I absolutely concede that it is not perfect. Then secondly, from BEOND, what we're hoping to do is understand more about the things that are important to adults with Smith-Magenis syndrome. And once we've done that first level, remember in that sort of hierarchy of description, we'll then be able to think about other studies that might be specific to adults in the same way that these kind of napping and school-based studies are really quite specific to children. I think we need to understand more about what might be most important for adults. We actually have a study coming up a bit later on with some collaborators across the network that will be looking at things like safety sleepers and working with NHS colleagues. That might be more important for sort of older children and children entering adolescence and early adulthood. But I would love to see us next thinking about what do we need to do that's specific for adults with SMS.
Thank you, Caroline. I think actually Stacey looks like she's answered Sally's message or question already, which was around the fact that her son is it takes beta blocker to block the melatonin signal during the day, and whether her son would be eligible. And actually Stacey's mentioned that the Rory sleep study would be appropriate for him, and also because of the age range as well for that, as in Stacey's is much younger. So and I think there also there was another question, so some of the questions have gone into chat, and I'm just looking through here.
So I think we've got one asking about somebody who is supporting adults, presumably in residential care or independent living. Could they take part in BEOND? You absolutely could. We need somebody who has, if the adult themselves isn't able to consent, we would need someone who has parental responsibility to consent for them to take part. But we've got a number of families who've taken part almost in collaboration with the care workers who are supporting the adults, because there might be questions you can better answer because you're maybe doing more of the day-to-day support of the individual, and some that maybe the parents or siblings, if they're still involved, might want to have some input in as well. So absolutely, that's a possibility. And then a second question from somebody who said that they're interested in OCD, repetition, copying and autism spectrum. All of those features we do touch upon within the BEOND survey. So it covers a wide range of psychological phenomena, including anxiety disorders, including repetitive behaviours, including autism, but also sleep, health problems, a wide variety of different areas. So yes, that would be fantastic. And then maybe I can hand this last question back to Leanne and Hazel, which is, what are family days?
Well, hopefully most people have seen the messages that went out a couple of weeks ago now regarding next year's kind of large-scale national event, if you like, which will be sort of as bringing. I'm using the phrase bringing information and activities together, because the idea will be a less formal conference approach to a sort of a slightly more informal event where we will be able to participate as families in some outdoor activities, but also share information and hopefully, actually, because it will be a smaller event, tailor that information to our audience, to our groups of parents and caregivers. So that's the aim of next year's event. Now, it's going to be smaller scale. It's a pilot, and we found a fantastic location, which is up in Derbyshire, in the Peak District. But we recognise that this is going to be difficult for some of our families to get to. It's not easy finding a venue that can kind of cater and accommodate our families. So we're going to take this event as our pilot and hopefully introduce more going forward and be able to bring it to other locations around the UK. But we recognise also that, you know, it's going to have restricted numbers compared to a normal conference. So what we would like to try to do is just have some family days where we can do something, again, much smaller scale, in different locations that again can bring some sort of activity and information sharing together. We haven't got anything planned yet, but we are working hard to try and get something organised. But At the moment, our focus is currently on trying to make the arrangements for next year's big national event, which will be over the course of the 16th to the 18th of August, which is when it's happening. So more and more information will come out on that. We're still very much in the planning stages of it at the moment, but it's coming together. The venue's been booked, and we'll be sharing more as you know, over the coming weeks. I'm just looking, there's quite a few chats all coming on now, so I don't know if there's any questions there for you guys. Caroline, your team, is there anything there? Certainly
I don't think so. I think we've hopefully answered them in the chat. Stacey and I are of one mind as we're both typing. Yeah, I think I can't see anything else. Just to say thank you from all of us. I'm so aware how precious your time is, especially in the evenings. So thank you for making time to come and listen to us. And we'd love to hear any feedback. I know there is also some feedback form in the chat from Leanne, which would be great to have completed for the foundation as well.
Yeah, so you can find that further up the chat comments. The recording will go out, I believe it goes out automatically to everyone that has registered, but I'll also share this event on our website, and obviously if anyone has any questions post the event, they can get in touch with me. I'm happy to forward on to the team. I'll also aim to share anything that was presented during this webinar with anybody that, you know, specifically wants it, because I have to say there were some really interesting slides in there. I learned something new, which was great. So and I just want to say a huge thank you to Caroline, Rory and Stacey for giving up their time tonight to do this webinar. Thank you so much, guys. Really appreciate it.
Thank you.
So I'm going to say goodbye and thank you very much, and enjoy your evening, everyone. Bye.
Bye. Thank you.
Bye. Thank you. Bye.
Thank you all. Bye.
Bye. There we go.
Well done, guys. Just frantically trying to remove people from the meeting.
Yeah.
Sorry, I was really long. That was not the 10 minutes I promised. Apologies. But I thought it went really well.
Yeah.
It's a big turnout for.
Yeah, it really was. For you know, only a few days advertisement as well. So hopefully we'll see a few recruitments tomorrow and in the days to come. Right, thank you both. Do take some time back as well. Don't yeah, come in early doors.
Yeah, there's a
Don't know what food I've got downstairs.
Oh, have you not eaten yet? I'm an early eater. I couldn't go and eat now. It's far too late.
No, it takes me an hour and a half to get back in the traffic. So as soon as I got back, I just came on a call. I've got curly whirlies. I was worried about like the claggy mouth situation. Eating caramel.
Oh, yeah, go and get some dinner.
Yeah.
Bye, guys.
So
Yeah, go and have a massive uncut sandwich, Rory. That's your style.
Yeah, that's every meal, every day. Yeah. All right. Bye.
All right, guys. See you tomorrow. Bye.